Recovery is poorly defined in most treatment studies of gambling disorders, demonstrated by inconsistencies in the outcome of variables and measures used to evaluate effectiveness. As a consequence, it becomes difficult to undertake comparative studies to determine which interventions represent best practice. In addition, many studies narrowly conceptualize recovery in terms of gambling symptoms and behaviors without incorporating interlinked psychiatric comorbidities and pervasive social impacts. The results of a systematic review are presented identifying the most commonly accepted metrics currently used in addressing successful outcomes. From this analysis, best practice guidelines for valid and reliable measurements of recovery are proposed. Unified reporting standards may be adopted by researchers and clinicians in the management of gambling disorders and will move the gambling field closer toward establishing a best practice protocol and consistency in reporting intervention outcomes. Alex Blaszczynski is a professor at the University of Sydney, Australia, and director of the university's Gambling Treatment Clinic and Chair, Responsible Gambling Research Group. He is the editor-in-chief of International Gambling Studies. He has evaluated randomized treatment outcome studies using behavioral interventions and has researched multiple aspects of the psychology of gambling. He developed a conceptual pathways model explaining the etiology of pathological gamblers and has reviewed responsible gambling and harm minimization strategies. Dylan Pickering is a research assistant at the University of Sydney's Responsible Gambling Research Group. He is undertaking a PhD, supervised by Alex Blaszczynski, to develop a self-report measurement tool for recovery in problem gamblers. This video has been professionally narrated based on a presentation by Alex Blaszczynski and Dylan Pickering on October 5th, 2016.
Hello from Australia, and it is bright and early, but I am Dylan Pickering, and obviously this is my supervisor, Professor Alex Blaszczynski. And what we want to report to you today is about the topic of treatment outcomes in gambling disorders. So the question we want to ask is, what exactly does it mean to recover from a gambling disorder? Is it to no longer meet clinical or psychometric criteria for that problem? Recovery might be to be able to control your gambling, as in to spend within one's own set limits, or to completely stop gambling at all. Is recovery to either eliminate or to control that urge to gamble? Or is recovery to repair the negative impacts that gambling can have on someone's life or their significant others, such as relationship issues or financial stress? In addition to this, there's also significant issues and inconsistencies with the measurement of outcome variables in treatment studies for gambling disorder. A perfect example of this is the unreliability of measuring gambling behaviour. There's firstly no consensus of whether this construct refers to expenditure, to frequency, or to the duration of a gambling episode, or a combination of these three indicators. And on top of this, various timeframes are reported, for instance, per session, per day, per week, per month, per year. Self-reported estimates of gambling are also quite inaccurate, and that's due to errors in recalling this information retrospectively. And in addition to this, there's no standard unit of gambling, like there is with alcohol, that can be directly linked to harm, because this is dependent on the individual's financial circumstances. And the problem with all this is that it prevents the comparison of results between different studies, between different treatment studies. And in effect, that undermines the development of optimal treatment approaches for gambling problems. As the slide shows, it's like comparing oranges to apples, essentially. So what we did here at the Sydney University is conducted a systematic review, the aims of which funded by the Gambling Research Exchange Ontario, or GRIO. The aims of which were to describe how recovery is measured in gambling studies, and secondly, to provide recommendations to improve those current practices. Firstly, the search strategy involves searches to 6 different academic databases, and including Google Scholar, where we entered different keyword combinations which were relevant to our topic, and a number of different combinations. So we had 1,400 studies which were returned, which were relevant to this particular topic. And of those, I condensed them down to 197, and that was based on a scan of the abstracts and a scan for relevancy. 197 studies were then reviewed by two of the listed authors, and that was where the eligibility criteria for studies were applied. So what we were looking for particularly were treatment studies for gambling disorder that included both pre and post measures, so a measure at baseline, then a measure after the trial, and they had to include at least a 6-month follow-up as well. So in total, 34 final studies were included that met that particular criteria.
Well, what's important also to understand is that we weren't comparing the nature of the treatments. It was simply, irrespective of the type of treatments applied, what were the metrics that they used to assess and measure the concepts of recovery or treatment outcome.
Exactly. Okay, so of our initial studies, the basic characteristics of these studies were quite a large variance in sample size, from small samples at 19 all the way up to 566 participants. The average age was 42. They were mostly male participants at 2/3. Studies were mainly from Western countries, including the United States, Canada, Australia, Spain, and Sweden. The main treatment intervention applied was cognitive behaviour therapy at about 68%. Some of the studies were also pharmacological, in addition to self-help workbooks and online modules, group programs such as Gamblers Anonymous, and other psychotherapies, including hypnotherapy in one study. The follow-ups range from between 6 months, which was, of course, our minimum follow-up, all the way to 36 months of follow-up assessments. Okay, so in the studies, we found that 62 different outcome measures were used in the 34 studies to measure treatment outcomes. We found that these basically fit into two key overarching categories. The first was that outcomes were specific to gambling, and these were typically conceptualized as primary outcomes. The second category were broader outcomes that were not necessarily specific to gambling, and often these were construed as the secondary outcomes. We also found that two different measures they fit into both of these categories. One was a timeline follow-back method, which is used to measure gambling behaviour, but was also used to measure alcohol use. And the other was a visual analog scale, which was used to measure gambling severity, but also well-being in individuals as well. Okay, so now looking at the gambling-specific outcomes, the first subcategory involved gambling symptoms and severities. So we found that most of the studies incorporated measures to evaluate problem gambling symptoms and the severity of these symptoms. This included self-report gambling screens designed to identify problem gambling, most commonly the South Oaks gambling screen, the Diagnostics and Statistics Manual for Mental Disorders, the clinical criteria for gambling disorders in the DSM. Also some shorter-term scales which are designed specifically to measure symptom severity and treatment. Most commonly this was the Gambling Symptom Assessment Scale, and also measures of separate psychological indicators of gambling disorder. So this might include mistaken beliefs, so erroneous cognitions, or urges to gamble. So based on this subcategory, we devised a number of different recommendations on our findings as well. Numerous studies administered the DSM via a self-reported checklist. However, the DSM is essentially designed specifically for administration by a clinical interview. And in situations where this face-to-face contact is not possible, we recommended that psychometric instruments are a good alternative to the DSM. Unfortunately, a lot of the studies use the SOGS, the South Oaks Gambling Screen, which is actually based on an older, outdated version, the DSM-3. So we recommend that since there's no DSM-5 based gambling screens, that DSM-4 gambling screens can be adjusted to suit the most updated version of the diagnostic manual. Furthermore, several studies included measures with timeframes that were actually longer than the follow-up period. So we advise that measurement timeframe should match exactly what the follow-up period is. And finally, a few studies also incorrectly used classification or screening instruments to measure severity. And the total number of symptoms that a person experiences does not represent actually how bad those symptoms are. So the use of these severity measures are more appropriate in this instance.
Yeah. One of the key issues with these particular psychometric measures, like the PGSI and the SOG, they've been developed in essence for a different purpose, that is to screen or identify the presence of probable or gambling disorders or pathological gambling. They haven't really been validated as a sensitive measure of treatment outcome, despite the fact that they've been used quite often for that purpose. So I think we need to start looking towards a more refined measure that is, in fact, sensitive to treatment outcomes.
Yeah. Okay, so the second subcategory of gambling-specific outcomes was associated with gambling behaviour. So again, most of the studies, but not as many as the previous subcategory, did measure gambling behaviour in some way. This was measured as frequency in terms of sessions or days gambled over a specific period of time. Expenditure, that is the total amount wagered or the net loss over a time period. And also duration, so which is the time spent on a gambling activity in a particular session. While some included multiple of these indices, as you can see by the uneven percentage amounts, many only included one indice of gambling behaviour. So based on our review of this particular subcategory, we recommended that multiple indicators are needed in this case of gambling behaviour or gambling involvement to gain meaningful data on this construct. We advise a frequency measure in terms of average days per month, and also expenditure in terms of net loss per month. In terms of duration, duration is less necessary. It's quite difficult to recall for gamblers who are doing self-report estimates, and frequency is also a high predictor of duration as well. In order to aid the issues with the accuracy of self-report gambling data, many studies, which we thought was quite useful, used a prospective diary during the trial to actually jot down their gambling behaviour. And in terms of retrospective data, a timeline follow back was also quite useful and is shown as validated to be inaccurate as well. Okay, so the second overarching category in terms of the gambling outcomes that weren't specific to gambling. Psychological functioning was probably the main subcategory of non-gambling outcome, and this was used in a large majority of the studies. This referred to comorbid disorders such as depression, anxiety, and substance addiction, but also measures of general psychological distress as well. So that often indicated by a composite of stress, anxiety, and depression. In addition to this, change processes were also measured, and that is the psychological mechanisms which are used to explain why the actual therapy works. So, for instance, mindfulness was measured in one study involving a mindfulness cognitive behaviour therapy. So in terms of our guidelines, we thought it was important to avoid overburdening participants. So by including many different separate measures of depression and anxiety and psychopathology can be quite burdening on participants, and this can add to the attrition rates of that particular studies. So in saying that, more brief scales of psychological distress can be sufficient in a study which is specifically focusing on evaluating a trial. The second category of non-gambling outcomes we found was functioning and well-being. These particular outcomes were not reported as often as the other categories, but in terms of recovery, they're no less important. Okay, sorry. In the brackets there, that is, I forget the actual thing. It's a measure of functioning in terms of work and social functioning, and the quality of life measure over there is an index of quality of life. We found that only one study actually measured both functioning and quality of life together, which shows that many of the authors believe that these constructs are actually interchangeable. While quite similar, both functioning and quality of life are quite distinct. Functioning, firstly, looks at the more tangible obstructions that people may face in everyday life, where quality of life is looking at more the subjective impact. And seeing that it's looking at the impact on the individual, we thought that a quality of life measure would be more appropriate in terms of measuring recovery in gambling trials. In the systematic review, we also analysed both if and how recovery was actually operationalised in the reviewed studies. We found that only a third of the studies actually define recovery. And this was in terms of, one, no longer meeting the DSM criteria, the maintenance of abstinence, a specific percentage decrease in gambling expenditure, or a specific scoring requirement on a self-report symptom measure, or alternatively a combination of these. So, for instance, not meeting a DSM criteria and also reducing expenditure by 50% met the criteria for recovery in some studies. However, 2/3 of the studies did not specifically define recovery. However, it was implied that either a maintenance of abstinence as well as or significant improvements in the included outcome measures did stand for recovery in these studies. So the guidelines based on this is it is important that studies clearly define what recovery means, and that definition should reflect the actual goals of the particular treatment approach. And on top of that, the treatment goals should be a collaborative effort between both the clinician as well as the gambler.
I think on that particular point, some of the studies indicated that recovery or treatment outcomes were determined more by the clinician rather than the gambler. So in other words, what they were saying is that we're looking towards a reduction in urges to gamble, but it's unclear as to whether that met the gambler's own expectations of what they wanted out of treatment.
Okay, so our conclusions based on this systematic review, and it's quite clear that the even balance between both gambling and non-gambling outcomes included in these studies suggests a multi-dimensional conceptualization of recovery, particularly in terms of broadening the scope of what recovery from a gambling disorder actually means in the current literature. So that is not only an improvement in gambling symptoms and involvement, but also improvements in psychological functioning and also quality of life as well. So by applying these basic measurement guidelines, will enable cross-study comparisons in order to refine the treatments for gambling disorders. It will improve the validity and reliability of such measurements of treatment success. And also reduce false positives or negatives. So that is incorrectly concluding that a treatment may be effective or ineffective when in fact the opposite is true. So to build on this, future studies need to expand on these recommendations and to provide clear and detailed measurement guidelines to evaluate treatment success or treatment recovery. The literature in saying that would benefit from a single and a multi-dimensional scale that measures recovery. Okay, so we've got a bit of time for discussion.
Yep. So I think overall what we're looking at basically is the multiplicity of approaches and particular measures that have been used to measure recovery or looking at treatment outcomes, and quite clearly they range from psychometrics that look towards responses in a variety of different instruments that measure severity or particular components of gambling-related harms, all the way through to the sort of more objective measures of reduction in gambling. And part of the difficulty quite often is that people come in for treatment and are in fact not gambling or have limited access to money. So when the treatment outcome, one of the questions is, are you still gambling, or do you have access to, or do you have any gambling urges or actual gambling behavior? The response then is no, and the question that is not asked is whether in fact they have access to money or not. And the question is that the urges often come back in the context of having access to money. It's similar, I think, to the situation with smoking, that if the individual does not have any cigarettes or is not able to smoke, given the context such as being on a long-haul flight, the urge to smoke diminishes until the approach time and the plane is coming to land, and the urges come back. And I think the same with the gambling is that the urges may in fact be subdued when the person has no access to money, or when the person is being monitored by significant others. And then the issue is when that money becomes available, will the urges come back? And those sort of things haven't been addressed, I think, in terms of the longer-term recovery. So I think the issue that came out of the systematic review basically is that there needs to be some general consensus in terms of how we go about measuring recovery. And I think that is a difficult task, because clinicians have different perspectives on what recovery means. And that again ranges from changes in gambling metrics all the way through to improved quality of life.